So good morning, everyone. My name is Joey Hunt. I'm the pharmacist in charge and an owner partner at Pharmacy Link. Uh, we are a specialty in compounding pharmacy, specializing mainly in topical pain management. Okay, so we're just going to go over here a little bit of some of the topical therapies that we use, both compounded and commercial, and their place in pain management, where they're most appropriate. So we'll start out with a little bit of history. Since 1999, some of the stuff's easy enough just to read, but that first number, the 165,000 people since 1999, that's kind of an outdated number. Right now, about 91 people overdose daily, which is about 33,000 a year on oral opioids or oral NSAIDs. This shows about a 2.5 increase from 1999. And also, as a side note, several car crashes. There's a high prevalence of positive drug tests in car crashes as well. So oral opiates, NSAIDs, and pain. So chronic opioid therapy can be effective therapy for carefully selected and monitored patients with chronic non-cancer pain. However, opioids are also associated with potential serious harms, as we know, including opioid-related adverse effects and outcomes related to the abuse potential of opioids. So, I'm not here to do a full pain management review. That's stuff that a lot of you pretty much know. But generally, we can see that opiates and NSAIDs are referenced heavily. Opiates always with this sort of a hedge nodding to their problems, yet accepting them due to the high level of efficacy that they have. Opiate NSAID safety risks. Of course, with opiates, there's addiction, respiratory depression, sedation, constipation, cost, drug interactions, and often, a quality of life trade-off happens between these two. With NSAIDs, GI irritation, GI ulcers, bleeding, increased bleeding risks, cardiac risks, stroke, hypertension, and also patients tend to view NSAIDs as benign with OTC therapy. They can. What I mean is, you may have a patient who is prescribed oral opiates or oral NSAIDs, and they'll self-medicate on top of that with OTC medications, thinking it's safe. Just some guidelines and notices that happened. So in the late 90s and early 2000s, people were looking for end-of-life care, which led to pain being treated as a vital sign. And it was originally designed to be a compassionate alternative, So in fact, recently the CDC has come out and said, not recently, a couple years ago, that for acute pain, oral opioid therapy shouldn't last any more than 7 days for acute pain. There's really no evidence that suggests treatment for longer than 7 days is effective or therapeutic or produces any better outcomes. So obviously we can see with these notices, you can read through this, pain's designated as a vital sign in the 90s. OxyContin hits the market in 2001, early 2000s. OxyContin hits $1 billion in sales. Moving on, in 2013, the FDA issues warning on long-acting opioids. 2015, hydrocodone's made to Schedule II. 2016, FDA issues warnings on opioids. Something's happening every year. In fact, gabapentin's about to be a scheduled medication. Tramadol recently was moved to a scheduled medication. So really, the powers that be are changing attitudes, yet they're not offering any alternative as to what you can do, basically. So this is where kind of our specialty pharmacy comes into play. Advantages of topical therapy as opposed to oral therapy. A lot of it's pretty common sense. You avoid drug interactions. You can have a less net dose. You have decreased dose of other therapies. Avoid systemic doses. You're treating the tissue or the area or the joint that's affected. You're not treating the whole body with topical therapy. It's very local treatment. Moving right along. Avoiding the systemic dose. Why would you give a full oral dose to treat the foot? It's going to go in the gut and be systemically absorbed. With adverse reactions and quality of life, we want good outcomes like mobility, decreased pain scores, decreased use of PRN medications. Typically, if a patient is in enough pain to require oral opioids and NSAIDs, then consideration of prescribing a topical should be thought of as well. And the reason would be because clinically you can reduce the amount potentially of the oral opioid or NSAID that you're using by using a topical, or decrease it or cut it out altogether if it's effective. Excuse me. Some examples of topical drugs. So commercially available are the Diclofenac preparations, Pensed, you may have heard of Pensed, Diclofenac solution, Voltaren gel, or Diclofenac 1, Diclofenac 3, which is actually indicated for actinic keratosis, but it's very effective if you can get it covered by insurance for arthritic pain and inflammation as well. Lidocaine ointments actually indicated for neuropathic pain. Fairly new therapy, Doxepin cream, is also out now. It has shown studies actually to be more effective for neuropathic pain as opposed to lidocaine as well. All of these therapies are usually covered by insurance, which is good to know. On the compounded side, what we typically use on the NSAIDs are diclofenac and ketoprofen, anesthetics, ketamine, lidocaine, bupivacaine, neuropathic, gabapentin, amitriptyline. Mix these all together into one cream. It's one therapy, one thing the patient has to use, and they can use it either on a schedule or as needed. Make sure I didn't miss anything. So here's some information on the efficacy of diclofenac. The American College of Rheumatology recommends topical NSAIDs such as diclofenac equally with oral acetaminophen, tramadol, or NSAIDs. Improved safety profile of topical diclofenac compared to oral is due to lack of systemic absorption and adverse effects. The local tissues are targeted, leaving other parts of the body largely unaffected. Also, we found that patients who use topicals prefer the topicals. They feel like they have more control over the dosing. And also, the therapies are usually very elegant as well. There's a lot of history and documentation on the usage and safety of topicals as well. All right, so lidocaine, as we mentioned before, it's approved for topical anesthesia, including postherpetic neuralgia, and then the off-label usages of ointments for pain and inflammation as well. It's studied and established efficacy in spinal-related neuropathic pain, painful idiopathic sensory polyneuropathy, so on and so forth through there. Pretty self-explanatory. Has similar efficacy compared to oral gabapentin or pregabalin. The problem with those two is you have pretty significant side effects, potentially weight gain, drowsiness. There are patients where that's appropriate therapy. Where that is not an appropriate therapy, a topical may be a good alternative, topical lidocaine, topical doxepin, or even that topical along with the gabapentin or pregabalin in an effort to maybe reduce the amount of pregabalin or gabapentin the patient is taking. All right, so topical treatment efficacy, the compounded therapy, often when it's studied against commercially available drugs, compounds show an increased efficacy or safety. Safety and efficacy has not been studied by the FDA. However, studies show better safety profile than most oral pain meds, and at least as safe as FDA-approved topical pain therapies that are commercially available. And again, that example is a compound that we do quite often. Patients, when a patient's refilling a therapy, it lets us know that it's working for them. That's a highly refilled therapy. Safety of topicals. We've been through some of this already. There's less systemic absorption, which means less ADRs. And even overdose situations don't lead to comparable systemic medication therapeutic dose levels. And what I mean by that is a patient takes 10 times the amount of an oral prescribed opioid or NSAID, they're going to end up in the hospital. If they apply 10 times the amount of topical diclofenac, likely nothing's going to happen, or they're just going to get a bad rash, something like that. So what we're saying is there's a broader therapeutic index with the topicals before we get to OD potential. So basically, there's no abuse potential with topical pain management, unless they find some way to eat it or sniff it or something.
Just wait.
Right. Nature finds a way. So the place and treatment protocol. First, we'll start with diclofenac. if you read down the first recommendation in CDC guidelines, I'll just read that verbatim. It's pretty strong. So this is the first recommendation of the CDC. It says non-pharmacologic therapy and non-opioid pharmacologic therapy are preferred for chronic pain. Clinicians should consider opioid therapy only if expected benefits for both pain and function are anticipated to outweigh the risk to the patient. If opioids are used, they should be combined with non-pharmacologic therapy and non-opioid therapy as appropriate. So for that non-opioid therapy, we're suggesting an NSAID, and for that non-opioid drug, and what better NSAID than a topical NSAID? So here again, what we're getting at is people are telling you, what you can't use. I'm saying some of the things that giving alternatives to things that you can use. So this kind of comes in a little pharmacy plug, but where we're getting at here is the normal prescription for anything really. You're going to see 50 to 70% actually make it to a pharmacy. Of those 50 to 70%, 48 to 66% are going to be picked up from the pharmacy. And then of those 48 to 66, only about 25 to 30 may be taken the right way in the first place. From all of that, 15 to 20% of prescriptions are refilled. So kind of starting to wrap up, you've seen how we've gotten here with the opioid crisis. You see the options, outcomes, safety, efficacy, and usage of topicals. Then this next slide is kind of where a specialty pharmacy like Pharmacy Link can come in and help with that. So Pharmacy Link is a specialty compounding pharmacy. We try to make it as easy as we can for the patient and the physician for prescribing. We have some of you physicians may have our prescription pad. You've seen it, I'm sure, around the office. But we make it as easy. We want to make it Amazon easy. You have a patient that you evaluated. You find them to be appropriate candidate for topical therapy. Check mark a box on the prescription pad. Tear it off. Give the patient information sheet that comes with it to the patient. They know what's going to happen in the next few days. You or your office staff fax the prescription to us, and we take over from there. Without getting too deep into line notices, grand rounds, I don't want to get too deep into pushing the pharmacy, but we make our goal is to create a patient, physician, pharmacist triad of communication and keep outcomes and adherence up for the therapy that you've prescribed. And that is pretty much all I've